I'm going to introduce you where we are in our first meta-analysis. So since the end of May, this last 6 months, we have worked hard, and I wanted to congratulate everyone in this group, each member, each team leader, each team co-leaders, assistant team leaders, because we work hard, and finally we worked thousands of hours, I think, and most importantly, we succeeded. So we managed to extract the data to answer these 4 big questions. Does varicocele repair have an impact of conventional semen parameters on isolated sperm defects? The second question was, does varicocele repair have an impact on seminal oxidative stress? The third question was, does varicocele repair have an impact on sperm DNA fermentation? And finally, does varicocele repair has an impact on natural pregnancy and live birth? So to answer these 4 big questions, PICO questions, with P is for participants, for interventions, comparison, and outcomes. For these big PICO questions, we used one SOP. In fact, 4 databases were screened, were interviewed, and in step 1, the abstracts of several thousand articles were screened in triplicate. We included studies, original articles for patients, and we include patients who had undergone varicocele repair and for whom an assessment of sperm parameters and/or an assessment of oxidative stress and/or an assessment of sperm DNA fermentation and/or natural pregnancy or live birth were assessed before and after varicocele repair. And for each article, we have to put a cross if the sperm parameters, for example, was studied in this article, or if it was for sperm parameters on natural pregnancy. So for this step 1, after this step 1, we performed 2 another step 2 and step 3. Step 2 was for quality of evidence. We used 4 scales, 1 to 4 scales for each article. You can see the scales here. And all researchers and verifiers have to evaluate the quality of the study using 4 scales. And in step 3, step 3 consisted in entering for each article the patient data and the numerical data of all articles. So if you have an example here of our master spreadsheet, because our master spreadsheet had over 300 columns and 6 rows for each article, you can see that we worked hard, because for each article we had to put, for example, laterality of varicocele, its grade, what was the classification used, what was the type of repair, and for numerical data. We have some total motile sperm count, for example. We had to put numerical data for each article or each group of patients. So it was a hard work, but we succeeded, as I said. And if we come to numerical data, we can say that we screened about 5,516 articles, come from Scopus, PubMed, Cochrane, and Embase. So after the step 1, we included 971 original articles. So we included about 10% of our articles. And after that, in the step 2 and step 3, at the end of step 2 and step 3, because we are almost at the end, we had included 586 articles. some articles, you can see that some articles were excluded at step 1 because they were animal studies, or they were from different topic. There was no varicocele repair on the article, on the study, so they were excluded. And in the step 2 and 3, some articles were excluded because data were not extractable, for example, were not statistically analyzable because the study used median, for example. Some full text were not found or not translatable. And finally, we have included about 586 articles, and only 4 German articles are always remain in progress, and they will everything will be finished very soon. I think next week. So we have these articles on all extract data for this, and they can be all this data could be analyzed by the best statistician in the world, I think. And Professor Ralph Henkel will talk about this during this meeting. So congratulations again to all, and to all of you on for this first meta-analysis, because it promised to be a very big success. So congratulations. And I can give the floor for Ripin.
Thank you, Florence, and that was a very, very impressive overview of what the systematic review and meta-analysis 1 achieved. And when you look at the number of papers that are going to be analyzed, it's many, many fold more than any other meta-analysis published in literature. So that is really amazing. Next slide, please. So buoyed by that, we're now planning the second and third systematic review and meta-analysis. So they'll start simultaneously because we have become better at doing what we did, and we've got more researchers joining the team. So we're going to have 6 teams, which we'll be talking about later, and therefore we can handle both of these studies together. So in my initial few slides, I'm going to explain the clinical thinking behind these topics, and then Dr. Ramadan will explain the SOP. But just to go back almost a year, all these topics emerged again from our collaborative global varicocele group when everybody was asked to send in their suggestions. These suggestions were then vetted down into the most commonly given suggestions. From that, 10 topics were selected and then narrowed down to 6 topics for meta-analysis. This is the second and third, which have evolved by consensus. Next slide, Florence. So starting with SRML2, this is actually a patient whom I see and I saw every week. So there's a couple who's been married 6 years. They have oligo. The husband has a clinically obvious varicocele, but tired after 6 years of infertility. They've already gone to the IVF center. They've planned and booked for IVF, but they came back to me saying, Doc, we're going for IVF, but there is this large varicocele that you diagnosed. Should we get that corrected before we go for the IVF? So this is different from our first meta-analysis, where we were talking of natural pregnancies. Now our concern, and this is a common concern because most patients come to us from the IVF department, next slide, Florence, is that if a couple is already committed to IVF, is there a role for correcting the varicocele before they go in for IVF ICSI? Now, what do I tell this couple sitting in front of me? If I look at literature, here is one meta-analysis with Sandro and Ashok. Next slide. And they looked at 4 studies. And next slide shows that 3 of them actually showed significant improvement in pregnancy rates when ICSI was done after the varicocele was corrected. And one study, next slide, did not find any difference. So we have only 4 studies. And here is another meta-analysis which showed that the odds ratio actually improved. Next slide, please. In favor of live birth after the varicocele was corrected before doing IVF ICSI. And they found this both for men with oligozoospermia and azoospermia. So these studies are there, but what do I tell my patient? Your odds are 1.699. So if I operate 8 couples like you, maybe 1 increase in pregnancy will take place. Next slide. So we are moving now from the era of precision, of evidence-based medicine into precision medicine. And if you tell a couple that get your varicocele corrected, we'll just come to that. Can we go back, please? If we tell a couple that get your varicocele corrected before the ART, we're putting them through extra time, expense, 1 more surgical procedure. It will delay the ART by 3 to 6 months. Your IVF specialist will hate you. And the most important question that we need to answer, is it worth it? And if so, for which patients? So this couple sitting in front of me, oligoacinovaricocele, booked for IVF. Should I do a sperm DNA fragmentation and then tell him you need a varicocele? Should I look at the grade of the varicocele and tell him, okay, yours is a small varicocele, you don't need it? Should I look at his FSH, his testicular size? These are true clinical concerns. And in fact, in the feedback that we've received from many of you, these were the queries that were raised about the study. And next slide. When we looked at our global varicocele study, which is in the process of getting written up, the same wide divergence of opinions, whether to correct the varicocele, correct it selectively or not correct it, was expressed. So what we are hoping is that the kind of meta-analysis we do, where we have many, many, many more studies than any other published meta-analysis, we will be able to tease out this nitty-gritty and answer specifically, precisely, which couple would benefit from varicocele correction, even when they are committed to IVF-ICSI. Florence, thank you. The next slide. So now we move on to the third meta-analysis that we are planning, which is equally controversial. So here is a couple non-obstructive azoospermia, quite clearly scheduled for a micro-TSA and ICSI, but also as a varicocele. I should not have put the word large. Let's just say as a varicocele. We don't know whether it's large or small. And the question, next slide, is that should this varicocele be corrected before the TSA, or should he do TSA directly? And if you go through literature, there's a lot of controversy. And the question we are trying to ask is that if we do recommend surgery, what are we hoping to achieve? Are we expecting sperm in the semen? Are we expecting a higher sperm retrieval rate? Or even in men in whom we could have found sperm, will correcting the varicocele improve the sperm quality so that the live birth rate is better in the group that had varicocele surgery? Next slide. So it's a tricky question, and it has been analyzed before. More than 11 years ago, we had a meta-analysis that showed that, 20 to 40% of men will get some sperm, few sperm in the ejaculate, often transitory, and there may be a rare spontaneous pregnancy. Another study showed that one of the predictors of who might benefit, next slide, is people in whom the biopsy shows either a late maturation arrest or hypospermatogenesis. But even with this information, next slide, it's difficult to decide who should be operated. I rarely operate, and I'll show you data from our global survey. Half the people don't operate. So if we are thinking of correcting a varicocele in a man with non-obstructive azoospermia, who should it be? You can see here a wide divergence of opinions. Should we be taking only those with very large varicoceles, with good sized testes? Should we exclude small testes? Should we exclude those with high FSH? Next slide. So if you look at our data again, you'll see that, next slide, please. You'll see that half the people, the blue boxes, are the ones who will advise surgery in most of the cases, and half to the left do it very rarely or occasionally or not at all. So we are hoping that through, again, our very detailed, extensive meta-analysis, we will be able to bring precision to our suggestion that which man with non-obstructive azoospermia should have its varicocele corrected and why. So with this clinical perspective, I now hand it over to Dr. Ramadan, who will again explain the SOP of the 2 studies that we are planning.
Thank you very much, Dr. Robin, for such great presentation and for explaining the impact of varicocele repair under different clinical scenarios. And actually, you made my job easy in terms of going into more details on the steps that we are going to conduct in systematic review number 2 and 3 concerning the varicocele repair. So for systematic review number 2, we are including the impact of varicocele repair on the outcome of assisted reproductive techniques. Next, please. As Dr. Rubin just explained, approximately 60% of cases who undergo varicocele repair would benefit from the surgery in terms of successful natural fertility outcomes. And in this case, there are 40% of cases that will remain without having natural pregnancy, and this category are the candidate for assisted reproductive technique, which is the second or the next level in the intervention in this case. And this 40% of cases of varicocele repair, these are the main concern of our meta-analysis number 2 and number 3. There are a few reports, as Dr. Rubin just said, in the literature that are covering the outcome of varicocele repair in terms of assisted reproductive techniques, and we will update the literature. We will go through more details. We will go through more studies in order to cover this important topic. Next, please. So our aim in this systematic review and meta-analysis number 2 is to investigate the outcome of assisted reproductive techniques, including IUI, IVF, ICSI, in infertile men who had undergone varicocele repair, and this group will be compared by a control group of men who had clinical varicocele but did not undergo surgery prior to ART, and they proceeded directly to assisted reproduction. Next, please. The main outcome for the second systematic review is the clinical pregnancy rate. This is estimated per couple, as well as the live birth rate. And additionally, we will go through fertilization rate and quality, embryo quality for these patients who undergo IVF and ICSI. And for the 3 ART procedures, we will also include chemical pregnancy and early miscarriage rates. Next, please. In this meta-analysis, we will include all human randomized controlled trials, case control studies, cohort studies that are investigating the outcome of assisted reproduction in infertile men with clinical varicocele, abnormal semen parameters who undergo varicocele repair prior to ART. We will exclude abstracts, conference papers, case reports, case series, reviews, and book chapters. And we will also exclude infertile couple in whom the husband has non-obstructive azoospermia in the context of varicocele, because this will be covered in the systematic review and meta-analysis number 3. And we will also exclude those cases who proceed for ART for a female factor infertility. Next, please. And this is a BICO model for the second systematic review, and our participants will be infertile men with clinical varicocele and abnormal semen parameters. The intervention should be varicocele repair followed by ART in the intervention group, and the control, as I just said, will be infertile men with varicocele repair who proceed without varicocele repair who proceed directly to assisted reproduction. And I just mentioned the outcome measures, the main and additional outcome measures. Next, please. As Florence showed in the meta-analysis, the first meta-analysis, we will almost follow the same strategy in terms of the data sources. We will conduct a comprehensive systematic search on Scopus mainly, as well as PubMed, Ovid, Embase, and Cochrane databases. We will create an initial keyword string on Scopus, and this will then be modified so that it is suitable for other databases. Our study will include all studies published till December 2021, and importantly, we will include not only English articles, but we will go through and cover non-English articles, as we just did in our first systematic review and meta-analysis. For data collection, we will first identify the articles through the database, as I just mentioned, and when we are done with the initial identification, all these articles, after excluding the duplicates, will be saved into a master monster Excel sheet, and then the articles will be divided amongst the teams so that the number of articles per team will be equal. The initial manual screening will be conducted in duplicate by 2 independent researchers. The eligibility will be dependent on the inclusion and exclusion criteria that we predetermine. And of course, we will follow the BICO model for our eligibility model. The full text, our researchers will be asked to download the full text of all potentially eligible articles, and then this will be uploaded to a Dropbox, which will be provided by the program. And of course, all researchers will have access to this Dropbox. Next, please. And this, please pay attention to this slide, because it includes the important information that will be retrieved in our second systematic review and meta-analysis. And of course, there are publication informations. The study design is very important because they are needed in subsequent analysis. The general data, like the number of patients, the age of patients and wives, and duration of infertility, these are important co-founders. The data related to varicocele will be collected, including the laterality, the grade of varicocele, the testicular size and type of varicocele repair. The data related to assisted reproduction will include whether there is a previous failed ART or not, the type of ART used, and the time from surgery to assisted reproduction. Sperm parameters will cover basic sperm parameters as well as sperm DNA fragmentation. The reproductive hormone levels will also be used, as they are important confounder, like follicle-stimulating hormone, luteinizing hormone, and total testosterone. The ART outcomes are already mentioned, and these are the main and additional outcomes in our study, and the remaining items will be used as for subgroup analysis. It's important to tell that this SOP is edited and modified after getting so many comments and suggestions by many colleagues who are present in this meeting, so that it is refined and made at the optimum level. Next, please. For quality of evidence check, we are selecting the articles based on their quality, and we used 4 tools for quality check, including the Cambridge quality checklist, which is suitable for all kinds of studies, and additionally we use 3 more quality of evidence check tools for randomized controlled trials, which include Cochrane risk of bias, the JADAD, and the consort. Next, please. The policy in our program is to ensure the accuracy of data collection, because this is a human work, as this is a manual search of data. So two important steps are followed in order to make sure that the data collection procedure is accurate. Is that all steps of data collection, including the screening, the data extraction, and assessment of quality of check, all of these steps are done in duplicate, and they are cross-matched in each subgroup. If there is discrepancy between two researchers, this is discussed and resolved through discussion. And if further intervention is required, the outcome or the results are verified by the team leader or co-leader, and a final decision is made in each case. Next, please. This is a statistical analysis that will be conducted in the systematic review number 2 and the third one also. This will include meta-analysis to determine the impact of varicocele repair on the ART outcome. We will assess the publication bias in each review, and we will perform, as I said, a meta-regression analysis in order to determine the impact of different confounders on the pooled effect size or the outcome. Next, please. And this flow diagram shows different steps, starting from screening, data extraction, the quality of check, quality check, data analysis, and then we'll end up with manuscript writing, review, and submission of the manuscript. Next, please. In the third systematic review and meta-analysis, we will be talking about the impact of varicocele repair on sperm retrieval rate and reproductive outcomes in infertile men with non-obstructive azoospermia, and of course, they have clinical varicocele. Next. As Dr. Ruben has nicely covered this topic, there is a growing interest in the last 2 decades on varicocele-associated non-obstructive azoospermia and how to manage these cases. And the research is focused mainly on the efficacy of varicocele repair in enhancing sperm recovery in the ejaculate and natural conception, and the outcome of assisted reproductive techniques in this selected category of infertile men. And as Dr. Ruben also said, that the literature is lacking and there is limited information regarding this point, and still the answer needs to be clarified. Next, please. With this background, our aim in this third systematic review is to investigate the effect of varicocele repair on sperm retrieval rate and assisted reproductive techniques in infertile men with clinical varicocele and non-obstructive azoospermia. And additionally, we will examine the impact of varicocele repair on sperm recovery in the ejaculate that takes place in some cases, and the chances of initiating a spontaneous pregnancy. This is a list of primary and secondary outcomes. It will include the surgical sperm retrieval rate, the clinical pregnancy, the live birth rate, sperm recovery, and spontaneous pregnancy. And additional outcomes will include laboratory outcomes like fertilization and good quality embryo rate, as well as clinical items such as chemical pregnancy and early miscarriage rate. Next, please. Like we did in the second systematic review, will include randomized controlled trials, case controls, cohort, which are investigating assisted and unassisted reproductive outcomes in those infertile men with non-obstructive azoospermia and clinical varicocele. Next, please. And we will follow the same BICO model in this study. Next. And the search strategy and data collection procedure will follow the same as that I just mentioned in the previous systematic review model. Next, please. Next, please. These are almost more or less the same. We will follow the same strategy. Next. Just a little bit change in the data extraction sheet, in which we will include sperm recovery in the ejaculate. We will include Johnson score, which is the histopathological pattern of testicular biopsy in these azoospermic patients. And of course, we will include sperm retrieval technique. Next. These are the same as the second systematic review and meta-analysis. Next. And the same policy also for accuracy of data collection. Next. The same scenario. I want to highlight some important points that we want to know about our expectations from the team members while conducting systematic reviews number 2 and 3. We will remind ourselves and all team members that we require good communication skills are required. We need people to respond immediately on WhatsApp or emails. Message. They have to listen carefully to leaders' instructions. They have to show respect and always act in a professional manner. It's important to show flexibility, interest, and enthusiasm. Be responsible and complete your assignment without being prompted. It's very important to be accurate in all steps of the research, because ultimately this research will be used for a decision making in a clinical situation. You have to make the least amount of mistakes, and of course all these research activities needs to be kept confidential. Next. And with this slide, I come to the end of my part, and thank you all for listening. And now I think it's time for Dr. Agarwal to return back and to provide some announcements.
Thank you very much, Ramadan, Rupen, and also Florence for excellent presentation related to all the 3 meta-analysis. The first one, as you heard, is about to end next week, but that will be ending in one aspect, but it will be opening in terms of the other aspect, which is the statistics, which is a huge effort, and my colleague Professor Ralph Henkel is going to elaborate on that. But let me introduce you to the members of the management team. Our management team has exceptional experts in the field of male infertility and andrology, drawn from all over the world. We have Rupen, who's a senior advisor. He is a uroandrologist, one of the top andrologists of India, and known all over the world because of his expertise in this field. He is a consultant in one of the major hospitals in India and has been practicing since maybe 3 decades, maybe more. I don't remember exactly the time, but we have been speaking and meeting constantly at meetings for last 20-30 years, and he has always impressed me greatly with his knowledge and his focus, and now with his leadership. Let me introduce my very good colleague Ralph Henkel, who is a wonderful person. He's not only now a chief scientific advisor in Logix Pharma, but he is also holds a lot of academic positions. Earlier, he was in South Africa. He was a professor there. He still holds a position there, but he moved to United Kingdom, where he is located right now, and he has collaborated with us for last 10 or 15 years, and we have multiple publications. He is the senior advisor, as well as he is the chief editor of a journal called Endologia, one of the most famous andrology journal in the world. Professor Florence Boitrel, also we call her Florence or Flo. She is a person who is the president of the Society for French-speaking Andrology, countries, and she has both academic and clinical positions. She's an andrologist, but also she is an IVF. She also directs an IVF program, and she is truly, I think, a person who is very talented, very smart, and extremely hardworking and dedicated. You heard about Ramadan. He was trained a long time. I can take a little credit. About 20 years ago in Cleveland Clinic, and since then he has really developed into one of the best andrologists, not only in Egypt but also internationally. And he has given so much of his time and energy to the projects that we are working on. So this is our project management team. We originally started just with Rupin and Ral, and as of last week, we invited Florence and Ramadan for their
Sheridan, take a right.
Please,
Sheridan, and on the left,
mute,
down a little ways is the garage. That's
can
the
you
best
mute your
place.
phone?
Because then
Can
there's
you-
bathrooms and showers.
We
They
will
want
go.
to, and I'll take the other one.
Okay, yeah. تعالي يا
Can we
أخي.
ask our
حتى
colleague to mute?
وين أغراض الكمل؟
I'm not sure who it is, so it is difficult for me to mute, but let me see.
Should be
Raneen,
running because running
mute your, I guess I was able to mute. Okay, please, just for, sorry to tell, but please keep your phones muted, microphones muted, so that we can conduct this meeting. We will ask you to speak when we, tell you, then please go ahead and speak. But everyone, even by accident, if your phones or your computers are not muted, please mute it at this time. Thank you very much. So we invited Florence and Ramadan to join the project management team, and let me show you what we do. So Florence, can you move to the next slide, please? So our mission is to set specific goals and objectives that are clear and time constrained. We provide the guidance. We develop the plans with details of timing and resources. We optimize the benefits from available resources, and also explore how we can get more people to join, monitor the performance of individuals and groups, and provide guidance, feedback, critical appraisal, and motivation. And more importantly, we interface with all our team leaders who have been handpicked, and to make sure that whatever is being done is done really, really well. And we are always looking at completing the things on time. So there is a whole lot of focus on gearing everyone, especially our team leaders, to manage the time, manage the people who are working with them. And remember that everyone who's working with us is volunteer. There is nobody who's being paid to join our program. Everyone who has joined voluntarily. They wanted to help, they wanted to be engaged, and those who are engaged more actively are the ones who are involved in day-to-day work. But then we have a whole list of people. May I have the next slide? This is again the mission of the management in a graphical manner. So you can see these are the things that we set the agenda. For example, we decided that we now need to move to meta-analysis number 2 and 3, as we are trying to complete meta-analysis number 1. So it was decided that it is time to introduce this. We spent the last 6 to 8 weeks developing the SOP. It had multiple meetings. Just between us, we must have spent at least hundreds of hours communicating, talking, and developing the plan. And then we actually invited people to provide their feedback. So what you see in the plan that was presented by Rupin, and actually more by Ramadan, is actually distilled information from hundreds of comments that we received from our colleagues. So the SOP, which is not shown, which is pages after pages of details of what and how we are going to conduct this, has been a work of collaborative effort. And this is all orchestrated by our team. Next slide, please. Now I wanted to introduce our new member of the management, which is Professor Florence. Florence, this is a very small biography. She has a very long biography, a lot of information, but I just picked a few things. She is a clinician, an andrologist, biologist, sexologist. She is like one in everything, and director of ART, head of ART. She is more importantly president of this French-speaking Society of Andrology. And she is very active in really giving us hundreds of ideas in how we can move our efforts and work that we are doing to be top class, something that has never been done in the world. So the meta-analysis that we are doing are really examples of things that we are pushing the boundaries, that we decided that we are not going to stop just with the English language articles. We are going to throw it to every single language. So we have Chinese, we have French, we have German, we have Russian, we have Farsi, we have almost any language that you can imagine. We had found experts within our a large number of global varicocele team, where we were able to invite and request them to translate these various articles, and we were able to extract that data. We also pushed that quality of evidence that you saw. Instead of one quality of evidence tool, we took 4 different quality of evidence. So in everything that you're seeing, we have really made it such so that whatever comes out of it will become the gold standard and will become the timeless piece of work forever. I mean, for many years to come, because such type of effort has never been done anywhere in the world. So I want to congratulate Florence for joining our team. Let's move to the next slide. We have this little bit of a presentation by both Florence, and the next person who's been invited to join in the management is Dr. Ramadan. So Florence and Ramadan, would you like to speak and say a few words?
Yes, I can. When Professor Agarwal and Ashok, I say Ashok, when you asked me to join the management team, I thought, wow, it's great. And 1 second later, I said, oh, I am a little stressed because I had to live up with. To live up to your expectation. So I will do my best to do even better. I know the team won, and I know other leaders. I know what it is expected for leaders, assistant leaders, and researchers, and I know possible mistakes we have done and we can improve. And I know the possible ways to do even better for our next SMA. Systematic review and meta-analysis 2 and 3. So I will make sure to keep an eye on the future teams, and I will be the link between the teams. And I just want to make our global project a success without borders, because no borders is our mantra. It's ambitious, but I believe we can have the chance to achieve this dream together, and I will help all leaders and co-leaders to succeed. So thank you very much for your invitation on the management team. I will do my best to do everything.
Thank you very much, Florence. Can we have the next slide? Okay, the next person that was invited was Dr. Ramadan Saleh, who was the team leader for team number 2. Florence was for team number 1. Actually, either team number 2 or 3, I think, Ramadan. And Ramadan is Ramadan is a professor in the Department of Dermatology and Andrology. He is also the founder of his own hospital called Agil in Egypt. He has so many other accomplishments in his career that is difficult to tell. But more importantly, for me, I am very proud that, as I said earlier, he was trained at the Cleveland Clinic and he spent 2 years of his life, early part of his life. He is still very young, in very close relationship with us in Cleveland Clinic. Since he left, we have remained friends and colleagues, and he has been collaborating and working on a large number of his studies. But more recently, he felt that and we felt that he is in the right frame of mind and time because of his work, that he can do more active research. So we invited him to join our Varicocele group, and now he has done so well that we felt that he will be a suitable, a wonderful candidate for the management. So Ramadan, congratulations, you are part of the management. Do you want to say a few words?
Okay, thank you very much, Dr. Agarwal, for including me in the management team. I'm very happy and very proud and honored to be generally a member of the global Varicocele research group and recently to join the management team. Actually, I would like also to thank Dr. Rubin and Dr. Ralph and Dr. Florence, other members of the management team. I would like to thank my colleagues and co-leaders in Team 3 who had helped me a lot and have done wonderful job. Dr. Ayad Ballani from Iraq and Dr. Rosella. They did a very good job, and they now will take care of Team 3 on their own, and I'm very confident that they will do a very good job. And I'm also thankful for my colleagues, the team leaders of other 3 teams, Dr. Florence in Team 1, Dr. Bart Henkel in Team 2, and Dr. Muhammad Arafa in Team 4. They have been excellent leaders and all of all teams, as Dr. Florence said, they have done wonderful job and they showed excellent work in the systematic review number 1, and I'm sure that they will do the same in the remaining list of projects. For me, I learned a lot of lessons joining the Global Varicocele research group a few months ago. I learned first that the international collaboration work is a very good way and an excellent key for success. The second is that I learned that we can work online. It is not necessarily that we are present physically together. We can work online and we can make use and benefit from the available online resources and tools and the social media, and we can conduct the highest level of research even though we are working online. The third lesson that I learned is that every member in the research team counts, and we have wonderful people with excellent and talents, and they are doing fantastic job. We learn every day something from each person. And when ultimately we collect all these good things from all these people, I think the outcome will be fantastic, and we can see this now. Sure.
I think we need to stop here and move forward,
Sure.
just to keep the things going. So, Florence, can we go to the next step, please? Okay, let's go to the next. So we have a leadership team. A leadership team essentially are those who are actively guiding the research, which have been logistically arranged under several teams. So each of those teams are guided by leaders, co-leaders, assistant leaders, and those are part of a group. Now we have invited several other colleagues who are not really actively engaged in our day-to-day guidance of projects, but just to provide us their comments and feedback, which are discussed online into a dedicated WhatsApp group. So we have invited these colleagues who are already part of the Global Varicocele and who are already collaborating on a number of projects. We have Dr. Hussein Kandil, a young andrologist, urologist from UAE, Professor Nicholas Garrido, the head of research at EV in Spain, a wonderful person and has a great deal of experience in statistics. Professor Park, Hyojun Park, who's the chief editor of World Journal of Men's Health, one of the topmost journal in the field of andrology and male infertility. Dr. Evie, also her full name is Dr. Paraskevi Wojciarski from Greece. She's a reproductive geneticist and a wonderful person who really likes to talk about and work in the field of andrology. So we are very pleased to have her. Dr. Rajinder Singh, he is a leader in genetics of male infertility in India and has published a really large number of almost 25 or 30 meta-analysis in all different areas of male infertility. We are very pleased to have Rajinder. Eric Chung, he is really a leader in the field of andrology and male infertility in Australia and has been collaborating with us for many years. We invited recently Dr. Mohan Kamath, who is a young a clinician and academician in the field of andrology, with very much involved in Cochrane review. He's editor or co-editor of many topmost journals. Professor Taha from Saudi Arabia and Egypt. He's a professor of andrology and a good friend of mine for a long time. And he is very active, very sharp, and very smart. So we are very pleased to expand our leadership circle in terms of people who are going to be providing us guidance in a much more active manner. Thank you very much. Next slide, please. Let's move on to the reorganization of research team and their mission. Next slide. So as time progresses, we decided now is the time for us to expand the leadership teams, research teams. Instead of 4, we really reconfigured these teams into 6 teams because we have so many more clinicians and researchers who have joined in the last 3-4 months that we felt that we need to expand and bring in more talent and more people the opportunity to become the leaders and really coach them and train them to take up these roles. And we have team 1, which is going to be led by Jimmy from Italy. He was working along with Florence. Florence is going to provide an overall guidance to all the 6 teams. But this will be led by Jimmy, and he will have my colleague, my fellow, Dr. Shin, and Andrea. Andrea is working in Italy. And then we have a lot of active researchers, Dr. Evangelos, Renata, Satimo, Fotios, and Keshav. Then we have some at the bottom who are our consultants, who are available if we need to consult with them, which are listed there. Next team, please, team number 2. Team number 2 will be led by our very good colleague, Dr. Murat, who has really shown that he is second to none. He is really a true leader, and he has already been leading the team when Dr. Ralph Henkel was not available. So he really has been leading the team. He has done a great job along with Amarnath. Here it will be co-led by Tan from Vietnam, Marian from France, who's a protege of Dr. Florence, and Hakan Kashkin. He's a new person. He has not completed training, but we have included him, and this will be confirmed as he completes his training and is certified by our group. Then we have a lot of researchers, Petrula, Christian, Kader, Sarah, and Herrick. Some of them are clinicians, urologists, some are researchers. And then we have at the bottom row are clinicians and senior researchers who are not actively engaged in day-to-day, but they are available if we have any questions or comments. Next team number 3, is going to be led by our colleague, Dr. Rosella. She is like a dynamite. She can manage 100 projects at the same time, but she is so good that she manages everything really well and does not make any mistake. She understands things very, very quickly. I'm very pleased. I hope she will be joining us in Cleveland Clinic in about 4 months' time, and she'll spend hopefully several years working with us. We have Ayat Palani, who has been a co-leader with Dr. Ramadan, and then Gokhan Sikar, we have invited him to join. Now, some of these people who have been listed as co-leaders have not been announced. We have not publicly announced or have them complete all the formalities for joining and sign the agreement that we have, and this will be done in the coming days. And then we have active researcher in the name of Dr. Carlo Giuliani, Dr. Kartikeya from India, Michelle Pironi from Italy, Azin from Iran, and Noura from USA. Then we have at the bottom row are those who are our consultants. Next, team number 4 is going to be led by Dr. Mohammed Arafa, who is currently in Canada. He could not join today because of some personal reason, but he will be listening to the recording. Then we have Dr. Gokhan Shalik, Christopher Ho, who has been a co-leader with Mohammed for some time. Then we invited Dr. Vineet Malhotra to become a co-leader. These have not been informed yet. And then we have active researcher Arman from Turkey, Mesut also from Turkey, Nivita from India, Raghav from India, and Dr. Abdullah from Kuwait. Next slide, please. Team number 5 are new teams. We have Dr. Giorgio. He's a very accomplished clinician and a researcher in the field of male infertility and andrology. We are pleased to invite him to become a team leader. Along with the co-leader Amrullah, we also invited Dr. Dama to become a co-leader, and Dr. Rami, who is our new researcher and clinician who has joined our team just about 2-3 weeks ago and is undergoing and completing the training really fast. He will join as one of the leaders under the leadership of Giorgio. And then we have Federica from Italy. Then we have Luis from Portugal, Marco from Italy, Masha from Iran, and Dr. Karman from Turkey. Next slide, please. The last one is team number 6. We invited Dr. Tunke to become the team leader of team number 6. Then we have co-leader in terms of Dr. Amarnath. We invited Dr. Sezgin to become a co-leader, and then one of the protege of Professor Florence, his name is Amin Hamza. He will become a co-leader as well. And then we have several researchers. Many of them are clinicians, some of them are research PhDs. We have Dr. I'm sorry, I cannot say his name very well, Makar Runis from Greece. Then we have Dr. Parisa from Iran, Dr. Pallav from Malaysia. We have Burke from Turkey, and Dr. Rinin from my lab here. She joined from Israel, and she's working with us from US. So this basically is the makeup of our 6 teams, and we will talk more about what they will be doing next. So I want to now introduce our team of statisticians. These are some of the most accomplished statisticians in the world. We have Professor Ralph Henkel, Professor Nicholas Garrido, Dr. Ahmed Haraz from Egypt, and Dr. Rajinder Singh. The one most important characteristic of each one of them that they have really proven themselves not only in the field of reproductive medicine and andrology and male infertility, but more importantly in the field of statistics. So they have a track record of conducting high quality biostatistical work and many meta-analyses they have conducted. So these people will guide us and they will independently conduct meta-analysis, as well as they will confer and they will collaborate with each other in terms of our meta-analysis. But we have decided that they will also conduct independent meta-analysis. So we will have 4 different outcomes, and we will see if they all match. Hopefully, they will all match. So this will provide us a unique ability to look at the results from all different directions, because meta-analysis, like anything else, is very much driven by the approach and the training and the experience of each of the person who's conducting it. There is no one way of doing these things. So I invite Dr. Henkel to shed some light about the approach for meta-analysis. Ralph?
Yeah, I'm available here now. Yeah, good morning, good afternoon, good evening, wherever you are. We have heard a lot of meta-analysis in these presentations, but where do we have to put the meta-analysis now in the whole scenario, in the whole arena of research? If you look at this pyramid, it starts at the bottom with background information, expert opinions, and then it goes up, cohort studies, critical appraised topics, and eventually even higher than systematic reviews. They, right on the top of this high mountain, we see the meta-analysis. And that is what we also see when Cochrane database, really Cochrane analysis, and always this is the top quality of research that can be done, and it is based on everything that is below. Next slide, please. Yeah. But what is a meta-analysis? A meta-analysis is basically a statistical analysis that combines the results of multiple scientific studies that are published. And it is important then to know that this is the most accurate way to draw conclusions. Of course, everybody of us is drawing conclusions from their own studies, but the meta-analysis is combining all these different studies. And thereby it helps overcome the diversity of different results from different studies. But on the other hand, we must not forget that any study and any analysis, including a meta-analysis, has challenges. So a meta-analysis is dependent on the studies that are available. So it does not always predict the results of a single large study. If I combine results from several smaller studies, statistically, the results show higher variability, then we might not sit with and actually obtain the best end result. So it relies on the availability of all the published studies that are available, and it has weaknesses. One weakness is that the method and other sources of bias are not controlled. So that in the end depends on the studies that we include in the meta-analysis. And finally, a good meta-analysis cannot correct for poor design or bias in the original studies. So meaning in the end, if garbage in, garbage out, but all this is what we try to actually avoid and compensate for in our approach in this huge meta-analysis. But what type of different meta-analysis are available? That again, it depends on the studies, that what kind of variables they included. Can be a risk difference, excuse me. It can be correlations, proportions, relative risks, continuous measures, odds ratios, or even from areas that occur from rock curve analysis. And we need to include all these different variables from the different studies, the number of cases, the mean values, the standard deviations, and this is very important. But I think it was Florence who said it before already. We cannot include medians. It must be the standard deviation and the mean values. And from all this, we need these data we need from the control groups as well as from the intervention groups. We will also need the total number of cases, the number of positive outcomes, and the identification of special groups that we want to analyze. Next slide, please. Next slide, yeah. And from this makes actually our studies, the first, second, and the third one, actually really unique and novel. We identify a large number of studies, and this has never been done in the world before. If you look at all published meta-analyses that are available, that is relatively small numbers, but they never included more than 5,000 articles. They never included all available languages. They were always looking for English language, what they could understood. But we actually translated and will translate in the coming studies all other available publications in different languages into English so that we can analyze this data. We will include the quality as a criterion. Like I said before, garbage in, garbage out. So this is what we need to understand. We want the highest quality of evidence available, and we looked for the different criteria of quality of evidence from a Cambridge quality checklist, Cochrane risks and bias, Juddart, and the consort guidelines. So all this will be included. And then we will also analyze different clinical aspects. It's not only one certain small part of andrology like sperm count, motility. It is the whole semen parameters. It's the hormones, oxidative stress, it's the sperm DNA fragmentation, and pregnancy outcome. It is a clinical outcome that is important. This is what patients want to know. This is what clinicians need to know. And then in the end, these data collections is in duplicate by trained, highly trained researchers working in tandem so that we really get confirmation if there is some problems or issues or discrepancies. And then with clinicians, so that you have the researchers on the one hand, plus the clinicians get confirmation and include or exclude the relevant studies. In the end, all this will then lead to the fact that the data extraction is then done with a large number of studies, which then allows subcategorization. And as you all know, subcategorization will finally lead to lower numbers, which makes then normal study less valid. But with our large number of studies that we go into with our analysis, we will have less problems with the subcategorization. And all these together, all these criteria that I mentioned, that will then in the end lead to higher accuracy, higher validity of these studies, and better outcome, better advice and counseling for our patients. And with this, I thank you very much for your attention.
Okay, next is the future of global varicocele, and I asked Dr. Rupin to introduce this topic.
So we're coming to the last part of our section for those of you who are feeling tired. And how this evolved is interesting. We were invited, Florence, next slide, by the World Journal of Men's Health to write a review article on experts reflect on the future of andrology. So in the spirit of collaboration, which has marked most of our activities, we asked a number of experts from our group to send in their ideas. We invited 33 experts and 30 of them replied with 185 ideas. Next slide. And when we went through these ideas, we found that while not all, in fact, many were not suitable for the specific topic of future advances in andrology, in themselves, they were excellent ideas for future papers and studies. And they cover, if we can see in the next slide, a very wide range of topics that were truly amazing. So when we looked at this, we realized that though we started as a group to study varicocele, we are actually now looking at our strengths, possibly a group that can look at every aspect of male infertility and related areas, covering topics ranging from artificial intelligence to artificial sperm and everything in between. Next slide. The other thing we found is that the strength of our group, which makes us uniquely poised anywhere in the world, is that we have a combination of very senior, very experienced clinicians, internationally recognized, with a wonderful clinical perspective to make whatever we do and write and create clinically relevant. We have an amazing pool of really hardworking clinicians and researchers who've put in hours and hours of work analyzing what seemed like an impossible task, 700 full text papers to be analyzed, quality control assessed, and the data extracted. But we have the people doing it. And as a group, and especially thanks to Ashok, we have enormous publication credibility. The acceptance rate of what we write is unbelievably high. And in fact, we have so many invitations ongoing and pending to contribute to special issues, articles, etc. And next slide, we have another 200 applications from young researchers and clinicians to join our group. So with all this in mind, we thought, how do we utilize these resources to the best effect? And so we came up with the thought, and here I will hand over to Ashok, the idea of creating a new group with a new name, a new logo, and a new purpose. So Ashok, if you can take over from here.
Thank you very much, Rupin. So if you look at the picture below, rethink, refresh, reinvent, why do we need to reinvent? I think one must ask, we are doing so well with what we started with. What is the need? And actually, people will ask why we are here together. And I think the common purpose of why we are here together is really to do something special. We attacked varicocele first, knowing that varicocele, knowing this subject, this disease for hundreds of years, is still there are debates, there are questions, there are controversies, and people saying that they don't believe there is anything to do with varicocele affecting fertility, or it has any real evidence that it is considered as a main cause of male infertility. There are people, there are clinicians, there are doctors, there are surgeons, there are gynecologists, there are reproductive endocrinologists, even some urologists who don't believe varicocele plays any major role. So when we have so much controversy, so much differences in opinion, we feel that the evidence that is out there is not enough to convince the people about the real contribution of this disease to male infertility and to the couple's fertility. So this was the main reason that we attacked first on varicocele. We created this group to bring everybody together. We believe at this time we have the track record of conducting this work such that we are going to really be very much be able to follow the lessons that we have learned conducting the first meta-analysis into the subsequent meta-analysis that we have outlined, number 2, number 3, and then later on maybe number 4 and 5 as well. But we felt that we have such a great group of talent, and what everyone is looking for is really looking for contributing to academic research, because the field of andrology and male infertility really is very weak in terms of good, solid research, good, solid studies. This is the major weakness of our field. And what we can do together is to build a collection of highest quality of articles, which will really dictate the treatment of couples all over the world. It is impossible for individuals or even few individuals to do it in such a way. What we have found by collaborating with such large number of researchers and clinicians, that we can do something which we felt and many of people feel is impossible. We have done something which is impossible. To look at the numbers and look at the things that we have accomplished so far, I don't think anybody will believe that this is something that is possible and is of the highest quality. So we decided that it is time to really expand our effort, remain completely true to our purpose of academic research. There is really no other interest of us bringing together. We are not interested in any kind of offices or starting a new society or anything like that. May I have the next slide, please? Our interest is to really develop the field of andrology from a research point of view. Looking at all the expertise that we have available, we know that we can conduct high quality research in terms of the meta-analysis, systematic reviews, cytometric studies, and a host of other studies which can be easily conducted in this online platform that COVID has given to all of us. We have become even more stronger than before because we had no idea that this is something that can be done. But COVID actually taught us, really educated us, that there are ways that we can connect, we can network, we can do things together. And I think this is the beauty of what we feel is with all the disturbing news about COVID, I think this is one of the most positive things that has come out of it. So what we felt is let us bring everybody together and branch out into writing of highest quality articles, whether it is an editorial, whether it is an opinion piece, whether it is a reflection, inkling, a systematic review, a mini review, a meta-analysis. We need to really generate highest quality of articles and with no shortcuts, which is really one of the main reasons when you are working alone. Even with us, with almost 1,000 publications from Cleveland Clinic, we feel that those articles really don't serve everybody. Of course, you can keep on publishing as many as you can. I realize that we really need to bring in people together as a team, as a large team. One person doesn't know everything and hardly anything, actually. So if we can combine the talent of hundreds of people together, which is very difficult to do, but we have done that in our meta-analysis number 1. And we have a track record of completing several studies. The study on global varicocele survey is completed. It is being written right now for those who are involved. We have conducted several side studies in between, which shows that we are able to collaborate digitally in the most effective manner by producing the highest quality of work. This is our mantra: no shortcuts, no limits. Everything has to go to the maximum. And I think we have the unique opportunity to have the experts from all over the world who are really motivated to work together. Really, I think so. Here, the idea is to really each team, each of the six teams that we have, and the people who have contributed, the idea will become the main responsible author, and they will create the outline of papers. They will then support the team of researchers who will do the search, screening, data extraction if needed. If not, then they will create a way that the work can be divided in terms of research and writing. And then it will be written by the clinicians. It will be written by senior researchers and clinicians together. So each group can write multiple articles, and we believe that by having 6 teams, we can increase the number of research and publications in the coming days to the maximum that has never been done in any part of the world. So this is my vision. Let's see the next slide, please. This is I just wanted to say a few words before I give it to Rupin. There are a large number of people who are contributing their time and effort, and we cannot be really we cannot thank them enough. We have all these fantastic teams and researchers who are helping on a day-to-day basis, spending their time completely voluntary. Nobody is really being paid to do what they are doing. This is exceptional. This has never been done in the world. In our program, we have these 4 individuals who are now taking over the burden of managing the work. The senior one is Dr. Kuroda or Shin. He is a fellow in our program. He is a trained urologist and a researcher who has done a lot of work back in Japan. He has come to our program already been 6 months for 1 to 2 years to really practice and learn about research in andrology. He is the main person who is interfacing with many of you. We have a new person, Dr. Keshav Karna, who is trained in Korea, and he is interested in male infertility, who's working with us. We have Dr. Renin, who has just joined recently from Israel, interested in male infertility, and a young research assistant who started working with us in the last 2 weeks. Her name is Alika, who will interface once she completes her training in all the things that are necessary for her to work. Next slide. Before that, I think, Rupin, we had a discussion about the logo, and do we have a slide for that, or that has been removed? You are muted.
Of the earlier slides had 3 things that we wanted to do. Rename our group, think of logo, and also register ourselves as an official group. So these were the 3 things that we were planning for the future.
No, go to the previous slide, Florence.
Okay.
Since it's possible that today we may not have time to invite all the experts who are attending the meeting to speak or contribute, we might invite people to write into us, and there the suggestion could, this is the slide. There we could request suggestions for new names for a group that would reflect the new vision that we have. Ideas for a logo. Ashok has promised a bottle of wine to the prize, to the award-winning logo that is accepted. And we have to see how we can register ourselves as a group so that it becomes an official group that is conducting the activities and publishing. So Ashok, if you can add to this.
Yeah, I can just explain that we feel that having one name of our group will be very helpful when we are publishing articles or announcing to more people to join. So something that will really bind us together because the global varicocele may not be a long-term name because we are going to branch out into many other aspects of andrology and male infertility. So a name will be very useful, which will identify. We will also think about a logo which will define us and register the group. And this is something that was very important. And Dr. Ramadan mentioned that we need to register our group in order when we are writing meta-analysis and other things. If we have a registered name of our group, that would be helpful. So all of these things are completely non-political. We have no ambition to create a society or create any kind of things which are already there. We have excellent societies in so many countries and so many great societies. We really want to remain very much independent of many of the societies, so we can think and work independently with flexibility. But also, perhaps if some society would like to sponsor us as a special interest group with no fee of any kind and allow us to give us the umbrella under which we can operate, we will be happy to consider something like that. But having a logo and registration of the group, these are some of the ideas. You may have some other ideas how we can really create awareness of our group. Please email that to me and copy to all the people within the management, and we will have a proper discussion as we receive your feedback. So please, we encourage all of you. These are some things which are loose ideas at this time, but we are trying to see if there is enough support and feedback from the membership from all of you, then we will try to formalize it and update you about where we are going. Let's go towards the last slides, Florence. So, Rupin, you want to add because we are towards the end, I believe.
Yes, I just wanted to kind of help you conclude by thanking everyone who has attended this meeting on a Saturday. Originally, we thought we would have time for discussion, but when we have such a large group, if everyone speaks even for a few minutes, we will be here for a very long time. And for me, in India, that would be past midnight. So we've decided that for this meeting, we're not going to have people talking, but we very, very much want your ideas because it's the collaborative ideas of such a high-powered group that has brought us where we are and which will take us where we want to. We have shared today the kind of vision that we have, but that's just one perspective, and we would love and we want to hear from all of you. Please write to us, and everything that is written is acknowledged, considered, assimilated, and implemented in the future. So with that, I thank, first of all, Ashok for creating this amazing group, which if someone had told me about it a year or two ago, I would have said is a pipe dream. But he's managed it with his energy and amazing interest to keep it alive. It's interesting. He was on leave this whole week, and his wife told him, "What leave? Instead of working from the office, you're working from home." So he's indefatigable. He keeps on working. It's his obsession, and I think you need someone at the top with that kind of vision and drive to keep such a large group together. So many of you here are very, very, very senior experts in your own country and in your own field, and you're here just because of your personal friendship with Ashok. And I think that strength is going to permeate through the group, and even the younger clinicians and researchers will benefit from this. So with that, from India, I will wish you good night. Well, Ashok, would you like to end by saying good morning?
Yeah, well, it is still morning here in Cleveland. It is 11:35. So for me, it's a good time. I just want to thank each and every one of you for making the time to attend this meeting today. And we are so energized and so excited that you could attend. And with your support, we believe that we can really move the mountains. What we have done as a group is something we need to be all very, very proud, and something that has never been done in the history of our field. So I want to thank each and every one of you. I also ask each one of you to consider nominating, recommending other members, other people who you know, who are your colleagues, who are your junior, who you feel fit into this voluntary model of academic research. And I think if you have, please recommend them. We'll be happy to invest the time to train them and bring them up, and hopefully they can join. So with these words, I thank you again. We have a recording of this today's meeting, which will be, the link to that meeting will be sent by my colleague, Dr. Shin Kuroda, after some time, once the video is ready. And in the meantime, please Enjoy the rest of the day if you are still in the day zone. But otherwise, have a wonderful evening and night, and hope to communicate with you again. So this meeting now is adjourned, and thank you very much. Have a wonderful day and wonderful evening and wonderful night. Thank you, everyone. Thank you to all the members of the team, and thank you to everyone in our leadership circle for making the time to attend today's meeting. Thank you. Thank you very much. Bye-bye.
Right. Good day and good night.
Bye bye.